Hi everyone, this is anesthesia in very few words. Did you ever think that you could actually inject an oil into the bloodstream? Well, back in 1973 in Scotland, Dr. Glenn did think about it and turned up with this white oily solution that we know as Propofol. It is an alkyphenol, which means it's an oil at environmental temperature. Its first name is 2,6-D-isopropyl-phenol, and its composition is very interesting since it resembles a cooking recipe and we don't find it in other medical drugs. Besides Propofol itself, that will be present in a concentration of 1 or 2% according to the commercial presentation, we can also find soy oil in 10%, glycerol in 2.25%, egg lecithin at 1.2%, which is to blame for the pain at the injection site, and sodium hydroxide, an antibacterial. Propofol gets contaminated super easily once it's open, so we only have 6 hours to use it since that moment, and it can be stretched up to 12 hours if it's loaded on an infusion pump syringe and is kept under cool temperatures. Now, why is it white? Simply because it has little fat drops suspended, and these react to the light dispersing it, therefore showing a white color. Up to date, we have 2 commercial presentations. Vials of a 1% concentration, meaning that contains 10 milligrams per milliliter in a total volume of 20 milliliters. That's a total of 200 milligrams of Propofol, and vials of 2% concentration, which contain 20 milligrams per milliliter in a total volume of 50 milliliters, and that's 1 gram of Propofol in total. It is such a famous drug that a lot of important brands commercialize it, like Fresenius, Brown, and they're all affordable. But how does a white oil put us to sleep? Well, it has more than one mechanism, but its principal use is as a sleep inductor. So we can say it's a central nervous system depressor. First, Propofol will go to the place where GABA-A receptor is bonded to the neurotransmitter GABA, the main depressor neurotransmitter. And once there, Propofol also binds to the receptor and helps GABA to open chlorine channels and increase chlorine influx to the cell, which leads to a block in the nervous impulse transmission. Because it has time to spare, Propofol also acts as an antioxidant and helps bring endocranial and intraocular pressures down. It also decreases oxygen brain consumption and still goes over to the NMDA receptor whereabouts, and there it avoids glutamate to act. Glutamate is an excitatory neurotransmitter. Propofol is strongly bonded to albumin. This protein helps it to travel fast in the bloodstream and reach every tissue, added to the fact that it's highly fat-soluble, which helps too. Propofol makes a stop at the cardiovascular system, where it produces vasodilation, decreasing pulmonary and systemic arterial resistance, and also blocks calcium channels, resulting in a negative inotropic effect. This will translate to hypotension with almost no variation in the heart rate. And the third stop is the respiratory system, where it relaxes the muscle of the pharynx and larynx and terminates all upper airway reflexes, resulting in apnea. But our body is wise and will try to assure some pulmonary volume first. So before the apnea appears, there will be an increase in both respiratory volume or tidal volume and respiratory rate. If we administrate a single dose, the apnea will last about 30 seconds. Thanks to its antiemetic properties, Propofol gives a hand at the vomiting center, lowering dopamine levels at the trigger area and serotonin levels at the area postrema. So far, it's been all good news, but there is one side effect that fortunately is very infrequent, and it's called Propofol infusion syndrome, which is basically a metabolic acidosis condition with rhabdomyolysis and hemodynamic instability. It happens more often in children exposed to high propofol doses for a period longer than 24 hours. And the chances of presenting this syndrome are higher if the patient suffered from head trauma. Treatment consists in suspending infusion and hemodynamic support measures. Propofol is a guest in our body. Unlike every guest, we care to know when it arrives, for how long it will stay, and when it will leave. As we mentioned, once we administer it and enters the bloodstream, it gets everywhere easily and fast, going first through the highly perfused organs, heart, liver, kidney, and the brain. This means it has a big distribution volume, and that it will get to the onset action spot in no time. This is also called arm-brain time, or latency, and it lasts about 30 to 60 seconds. Then it will take 2 to 3 minutes to accumulate in the brain until it reaches a quantity that's enough to produce a peak of its effect, and then it's free to continue its route through the rest of the organs. It is a tri-compartmental drug, which means that it will continue distributing through body compartments, from those of higher perfusion to those of lower perfusion. Now that we have cleared when our guest arrives, it is turn to ask how long will it stay. Its first attempt to leave the body will happen on the first 30 to 60 minutes, which is the time that propofol takes and start its return from the low perfused organs to the bloodstream and plasma again. Then it finally remembers to use the big door to exit the body and goes towards the kidneys to be completely eliminated. This process takes about 4 to 6 hours. The lungs and liver also contribute to its elimination and metabolism. Luckily, propofol has a high clearance rate, which makes it difficult for it to accumulate in the body, but at the same time makes it necessary for us to use it in an infusion pump if we want to keep the effect and concentration. If we administer a single bolus, patient will be awake in about 10 to 15 minutes. But if we were using an infusion pump, patient will take up to 20 minutes to wake up. Doses are wide and depend on the effect we're looking for and the patient's characteristics. General range is from 1 to 2.5 milligrams per kilogram. If we want to do total intravenous anesthesia, we can use Robert's scheme, which is what we know as 10-8-6, and means setting the infusion pump to 10 milligrams per kilogram per hour for the first 10 minutes, 8 milligrams per kilogram per hour the next 10 minutes, and 6 milligrams per kilogram per hour for the rest of the surgery. Lately, it has been suggested to change the scheme to 8-6-4 in order to make the most of synergic effect with other drugs, because almost always we use more than one drug, not just propofol. The other option is target-controlled infusion, where dose will be provided by a math model that senses plasmatic concentration of the drug, and the range can go from 0.8 to 8 micrograms per milliliter. Last, we have contraindications. Absolute ones are allergic reactions, or that the patient has a contraindication for sedation or anesthesia itself. And relative ones are elder, deteriorated patients, pregnant women, children under 3 years old, and it's used in infusion pump for children under 12 years old who might be in the ICU. Well, that's it for today. If you liked it and you want me to make a video with a particular subject, you can leave it in the comments. Thank you very much, and I will see you on the next video.